Hey, we're sponsored today by OsteoStrong. OsteoStrong here in Birmingham focuses on helping strengthen your bones. So they're great for people with osteoporosis, if you're pre or postmenopausal, if you need strength or balance training, even if you've got chronic pain, they can help you. They are not a gym, they're not a medical clinic, there are no pharmaceuticals or supplements. They're a place where you go once a week, literally takes just a few minutes. They've got 4 devices and they've got an experienced technician who'll help you. You do a couple of very simple movements on the devices. And what happens is this will stimulate your central nervous system to trigger new bone growth. Now this process is backed by science, but the best way to learn about it is go to their website. It's simply osteostrongbirmingham.com. And you can go there. They've got a video of some of their client testimonials. They've got some folks who've talked about what it's done for them in terms of bone mineral density. They're conveniently located on Cahaba River Road. They're right behind, kind of behind Grandview and near Acton Road. And you can call them too. Call them at 205-203-8755. Thanks very much to OsteoStrong, and on with the show. All right, guys, we're back with our osteoporosis talk with Dr. Chris Heck of Southlake Orthopedics. I'm Steve Spencer. I'm the founder of the Birmingham Medical News. Since 2004, we've been providing the Alabama healthcare community with all sorts of information on healthcare. We're sponsored by Kassouf & Company. Kassouf & Company is an accounting firm in Birmingham that actually was founded in the 1930s, so it's almost 100 years old. And while Kassouf works across all industries, for our purposes, they have a really great experienced healthcare consulting practice. We are actually in their studios today. They're just fantastic for us. Anyway, today we're talking about osteoporosis, and we have Dr. Chris Heck, who's an orthopedic surgeon with Southlake Orthopedics. Dr. Heck, after earning his medical degree, did his residency with the University of Kentucky, and then went on and did a spine fellowship with Duke. And so to start out today, Dr. Heck, I imagine so many people have osteoporosis and don't know it, or at least early stages.
That's right.
Yeah.
I saw a lady in my office this week who had it after a compression fracture in her spine, and was talking to her about doing a procedure to stabilize the fracture and get rid of her pain. And her daughter in her, I think, mid-50s probably was sitting next to her. And I said, this is you're genetically predisposed to this. And the daughter was like, really? So I can have osteoporosis? I said, yeah. And I said, you're kind of at that age in your life where maybe we get you on an antiresorptive because you're not that far down that slide yet, right? So if we can catch you before you get down that slide, we can keep you at a good level. So even though she's never had a fracture, she's only in her 50s,
right?
She's going to make an appointment in our office just to get an evaluation. And if her bone density does come back abnormally low for her age, then we'll probably put her on an antiresorptive. If it comes back pretty decent, because she has the family history, probably repeat her bone density every 2 years, which is the recommendation by insurance companies and the FDA. And we check them every 2 years. And if we start to see a steady decline, we'll say, hey, look, 2 years ago you were here. It was adequate. Now you're here. Next time you could be here. Why don't we get you on something and keep you where you are?
And she wouldn't have known had she not taken her mom in.
That's exactly right.
Yeah. So I'm guessing there must be a lot of women in their 50s, maybe early 60s, who at least are in the early stages and have no idea. Because you probably don't think about this in your daily life.
No, you don't, but it's kind of like when you go to your doctor, at a certain age, everybody's supposed to get a colonoscopy, right? At a certain age, if you're female, you probably should be getting a bone density just as let's find out if you're having a problem. But a patient may go see their doctor and have a laundry list of health problems, and if this isn't causing you any problems, which it won't until you break your hip, then they may not think about it.
And also, there's so few people, especially, with limits on health insurance, and we got so many uninsured folks who probably never
They'll
take
never
a
know
proactive step.
they'll never know until they
Right.
come in the hospital and with a broken
I mean,
whatever.
I don't know the percentage of uninsured Americans, but it's pretty high.
Yep, I
So
would
you,
agree.
and if you don't have insurance, there's no way you're going to check on that before you have a problem.
I would. That's you're
Right.
in medicine. You never say never, and you never say always. But in that stipulation,
Yeah.
I would say you're right. Never
Pretty
is
close,
an
at
adequate
least.
word.
Pretty
Yeah,
close.
word.
And even folks with insurance, if their insurance may not cover as many I don't know how that with various
Yeah,
insurance.
they're just like colonoscopy. There are age requirements. You're not going to get insurance approval for a bone density on a 30-year-old.
Yeah.
But at the right age, and then again, they don't unless there's a significant problem developed. They don't allow you to repeat it, but every 2 years. Now, I guess if you broke and you got evaluated, and then you broke you got on medicines and you're still breaking, maybe you could get you could get approval through a special request to get it. But usually that's not even in our clinic. We've never really done that. Patients ask for it because they're worried, and 2 years is kind of a long time to wait, and they want to see, is this medicine really helping or not?
Right.
But you just got to tell them, number one, we can't unless you want to pay out of pocket, which nobody will.
Yeah,
and
right,
two is,
right.
you want to let the medicines have time to take effect. This is not an immediate turnaround. It's not going to make your bone density all of a sudden just shoot up because you took a medicine for 2 months.
Yeah.
So 2 years checking it is very appropriate.
And okay, obviously somebody who's had a fracture, but for people who haven't had a fracture, and I know it varies, with different insurance companies, but is there an age at which you sort of a minimum age before you can just go and take tests, just like for men with colonoscopies or everybody with colonoscopies?
The National Osteoporosis Foundation, there actually is an organization called that. They have a recommendation that every patient who breaks a bone over the age of 50 get an evaluation for osteoporosis. That even includes if you were banged up in a car wreck. Of course, if you're in a car wreck and you break your thigh bone, your femur, you expect that. But who's to say a woman with osteoporosis doesn't get banged up in a car wreck? Right? As an orthopedic, you can probably ask any orthopedic surgeon who takes call. And we've gone and called in because, a 70-year-old woman was in a car wreck, and we go to operate on their bone, and it's mush. I mean, bone's supposed to be knock on wood, and it's just...
Man.
And so that patient, although she had a high-energy injury, has osteoporosis and a fracture. So how do you know which patient truly has osteoporosis or not? The National Osteoporosis Foundation recommends if you break a bone, I don't care if you're stepping off the curb and you twist your ankle, I don't care if you're if you're a weekend warrior and you're 55 and you're playing basketball, or you get in a car wreck, or you fall and break your hip at home. If you're 50 or over and you sustain a fracture, the recommendation is to get an evaluation. Doesn't necessarily mean you're going to get treated. Maybe it was dumb luck that you broke your ankle. But that's probably the best way to catch the majority of people who have undiagnosed osteoporosis.
For folks, let's just say over a certain age, or over 60, obviously it'd probably be really good if you're a woman well into your 60s to get a test.
Yes.
But does insurance have any? And I know it varies, but does insurance pay for that sort of proactive test at a certain age?
Yes. I don't know if it's at 50 or 60. I don't know what their specific age is, but but yes, this is obviously insurance is it is cheaper to be proactive than retroactive in medicine,
absolutely,
right? And so insurances are interested in identifying this problem. Exactly what their age is, I guess I don't know, and potentially every insurance has their own, it may be plus or minus 5 years, but we have not had a problem getting this authorized and approved by insurance.
And what are you finding on average the age range from your female patients and then your male patients?
Yep. So females will start getting it without any other major medical issues. Like I mentioned earlier, hyperparathyroidism. Somebody has a parathyroid adenoma, which is a non-cancerous tumor in their parathyroid gland, which is in your thyroid gland. And if it secretes constant parathyroid hormone, it actually makes your bones just become very soft because it stimulates the cells that absorb the minerals, and so if they're stimulated, they're just going to constantly, because you got this adenoma. Sure. So barring any other kind of issue like that, men who have low testosterone, they would have early onset too. barring medical conditions like that, the average osteoporosis in a female is 50s and over, 60s is when we start seeing it, and men is 70s and 80s.
But I mean, the folks that come into your office, or I guess they're almost always people who. Yeah,
that's
about
right.
what you find.
That's what we see.
What is the youngest you've seen?
Probably mid to late 30s. Wow. And it was a female, and she had for, I don't remember the reason, but early in her life, she had a hysterectomy and had her ovaries removed. Well, the loss of estrogen, the loss of those hormones, has an effect on the cells in the bone as well.
Okay.
And she got very early onset
so she's going to have to
osteoporosis.
Be careful for the rest of her life.
So number one, she presented only because she had a fracture at a very young age. That was a low energy fracture. Then we got her bone density, and you're just like, how? And then you go into the history, the personal history of it, and you're like, oh, I had a hysterectomy, at age 15 for whatever reason.
Oh, wow. Okay.
And she's now lived the last 15 years without these hormones, which help keep your bones strong.
Okay.
So it can happen. Those are the outliers, right? Those are way out on the bell curve, but it can happen. I remember, I don't really know anything specific about why it happened, but when I was in my training at Duke, there was a cardiologist fellow. He was there to train to be a cardiologist. And cardiologists do a lot of their work doing like stenting for heart clogged arteries, things like that. So they use a lot of X-ray, and so they wear lead aprons to protect themselves from the radiation exposure. Well, lead aprons are heavy; they're made of lead. He was he had multiple fractures in his back from wearing heavy lead, which I wear as well because I operate and I use a lot of X-ray equipment. But his bones were so poor that he broke his bones, and so then he got sent to the orthopedic side because they were trying to figure out, how do you treat the broken bones? First, you're like, well, why does some guy in his 20s get?
Oh, he was that young.
Yeah. Wow. And I don't know anything about his history, but here's a guy who's in his 20s who's getting compression fractures from wearing lead. Wow. Obviously, I guess the future of him wearing lead for the rest of his life is probably not a good idea.
Yeah. Did they find out? Was there some sort of osteoporosis?
I wasn't part of his care team. I just remember the story. So those kind of one-offs, they're out there, but that's not the majority of what we see.
Sure. And I guess, there's a lot of people. I mean, I guess there's so many people out there who probably have it, or at least early stages don't know it. Why do people need to treat it?
The goal is to prevent future fracture. First of all, a lot of patients will get the words osteoporosis and osteoarthritis mixed up. They sound a little bit alike, especially if you're not in the medical vernacular, you get confused. And so osteoarthritis is a painful condition. You lose cartilage in your knee joint, your knee hurts because it's bone on bone. And so people will come and they'll ask, well, is this going to help my pain? No. The ultimate outcome, the ultimate goal of osteoporosis treatment is to prevent a future fracture. Why? Well, future fractures require healthcare. Healthcare means dollars. So to the healthcare system, to the insurance companies, to Medicare and Medicaid, it's money. So we can prevent a fracture. We can prevent you from seeing your doctor. We can prevent you from having surgery. Surgery and hospital bills go through the roof. Yeah. Then there's complications of surgery. We all experience that. And so then there's more dollars in the healthcare bucket. Yeah. And then it's also just for, patient lifestyle. You can't do anything when you got a broken hip. Right. You can't do anything when you're on crutches or a broken ankle. So the goal is to prevent a fracture. That's the ultimate number one. Why do you want to get treated for osteoporosis? To prevent a fracture and prevent the healthcare expenditure and the potential complications of either intervention and also of the problem you had. Like I said, you get a hip fracture, you lay in bed, you get a bed sore, you get a urinary tract infection, you get a pneumonia, you get a blood clot. Yeah, it's a problem. And
earlier the one the statistic you mentioned that just blew my mind is that 33% die after a year. That's a good enough reason alone to never do it. And one thing you had mentioned in a previous article you had written was that if somebody's had a heart problem, they're going to be proactive to make sure they don't have a heart problem in the future. But that hasn't been happening for the most part with people, at least if they have a fall and a break.
Right. So this one, I went to the National Osteoporosis Foundation meeting one year, continue the education, learn about what new techniques. And they had a gentleman who gave a presented a study he did. He was at a Kaiser Permanente. Kaiser Permanente is a healthcare system out in California, I know of.
Yeah.
Right? Kaiser Permanente it's everything. They are the insurance company. They are the employed. They employ the physicians. They own the hospitals. It is everything in healthcare under one big umbrella. The benefit of that, and you can go into all kinds of conversations about is that good or bad, but the benefit of it is all the medical records are kept under one solitary system. So if you want to go mine data, if you want to go research, and you want to make sure that you capture every data point for a patient, if a patient goes to, here in Birmingham, we got many hospitals. They're all owned by different systems.
Yes, I know that's been a problem.
If a patient goes to one hospital system and has a hip fracture, but then let's say they have a pneumonia 2 weeks later and they get admitted to a different hospital system.
And they don't know about hip
fracture. If I'm going to go and look at all the medical records for hospital one and say, oh, everybody who gets a hip fracture does well, it's because everybody who does a hip fracture who gets an infection goes over to the other hospital, right? And I'll never know that. So the benefit of this was it is one big system, and as such, you can collect all the records because patients, even if they own like all the hospitals in the area, and so unless you go like out of state, patient's going to go to a system-wide place of care. Anyway, that's kind of the background on it. So they did the study, and what they did was they followed for a year. I think it was a year, maybe two, but they followed for a good amount of time. Every patient who presented to an emergency room with a heart attack, and then every patient who presented to the emergency room with a hip fracture. They didn't go after all the osteoporotic fractures. It was just easy enough to say all hip fractures and all MIs, myocardial infarctions, heart attacks. And what they found was within 1 year, 80%, roughly 81, 82, but 80% of patients who had a heart attack were put on a beta blocker. It's a medication that helps prevent, it's been shown to prevent future heart attacks.
Right.
So patients come in, they and their family are scared. Oh my God, I had a heart attack. I could have died, right? And their doctor says, you know what? We don't want you to have another heart attack. You survived this one. You may not survive the next one. We're going to put you on a beta blocker. 80% of patients got treated for a heart attack within a year. During that same time period, they followed hip fracture patients. Hip fracture patients, only 20% got treated for osteoporosis. And having treated osteoporosis for over a decade now, the reasons are, I shouldn't say reasons, the rationales just kind of sometimes blow my mind, right? Little old lady may break her hip and say, I don't want to get on another medicine. I'm on too many medicines already. Well, are you on too many medicines that you're going to break your next hip? Do you want to go through this all over again? You broke your hip. You're in the hospital for a week. You had surgery. You went to rehab. Your family had to take time off of work to come take care of you. You're at home now. You now can't walk by yourself. You only can walk with a walker because you're weak. Do you want to go through this all over again? You put it to them like that, even the patient, the older patients may say, I don't find whatever. But you tell their children who have taken off of work, flown in from another state to help take care of mom and dad, and the child's like, Mom, you're getting on that drug, period. I don't want to hear about it, right? So there's that. Patients say, oh, I had a hard fall on concrete. Well, all concrete's hard, but not everybody who has a fall on concrete breaks their hip, right? Then there's the doctor side. We talked about it earlier. The surgeon says, hey, your hip fracture's fixed. It looks great on x-ray. Moving your leg around, everything looks good. You're great. Call me if you need me. Well, you're not great. Your hip is adequate, but your bones, they're shot.
Right.
I've heard it's too expensive. That is true. Osteoporosis drugs, some insurance companies, they don't pay for it all. Patients have a copay.
Okay.
And some of the medicines, especially anabolics, are much more expensive than the anti-resorptives, especially if you have a limited insurance policy or no insurance. I will say that most of these drug companies, the reps that come around are very they advocate for their patients, and they're very proactive, and they want to make sure that everybody who needs treatment is treated. And so there are often programs through these drug companies that if you can't afford it, they will either provide free samples. We have free samples in our office we give out periodically, or the company themselves have a program. You have to apply to it, and if they deem you adequate, then they'll provide you a card that basically pays for the medicine. So everybody can get treated. It's just a matter of does everybody know they need to, and does everybody want to get treated?
Yeah, because what you're basically telling me from the Kaiser study is that incredible amount of people with osteoporosis are not getting treated for it. It sounds like.
Yeah, because they
Yeah.
think once their hip's fixed,
They're
once their
okay.
ankle's fixed,
They're okay.
I'm good.
Yeah.
But then you take an X-ray of it, and it's like looking through a stained glass window. You know, it's the bone is very poor.
And I wonder if a lot of people just assume, well, hey, that's part of getting old. You know?
Right.
Because we see a lot of old folks, like you said, on walkers or maybe a cane, or you start to, slump a little bit.
Yep.
People may think, well, that's just old age.
I guess so are heart attacks.
Yeah.
Right? Just accept it. You're going to have another heart attack. Just accept it.
Yeah. And they don't do that.
That's right.
Yeah.
That's right.
Yeah. Hey, also, okay. Clearly, in the last 20 years at least, it sounds like we've gotten some pretty effective drugs from first the anti-reabsorbents and now the antibiotics. Have we learned a lot since you, going all the way back to the start of your career, have we learned many new things about osteoporosis? Or just not necessarily new, but have we learned much about the condition that we didn't know?
Yes, I was going to say, they know it exists, and we definitely know how to treat it better, but we've also learned additional risk factors. So, as I mentioned previously, to diagnose osteoporosis, we will take, hey, you broke your hip or you broke your ankle, whatever. We get a bone density. We take an X-ray and your bone quality looks like junk. You do a surgery and their bone is mush. And so you say, oh, yes, you have osteoporosis. Well, this kind of gets out of practicing, and this is more in the research side of things, but they do some special CT scans now where you can look inside of the actual bone and it looks moth-eaten. So when you take an X-ray, you just basically take a two-dimensional image and you say, well, how much of this X-ray gets through the bone, and that tells you how thin it is. But the problem is there are some conditions where if you do a bone density, their bone density may say it's very high. But there are some new tests being done out there. They're not quite in clinical practice yet to try to appreciate some of the finer points about maybe their bone density looks normal, but then if you actually did this fine CT scan, the outer structure, which we call the cortex of the bone, while on X-ray may look good, but on the CT scan, it's actually kind of moth-eaten. And again, they'll identify patients with it. But getting CT scans on everybody is costly. It has radiation exposure. It's not the standard of care currently.
Okay.
So are we learning about more stuff? Yes. We just know it exists. We have definitely improved on treatment. I think our biggest obstacle to overcome is to improve on the identification and the realization that this is a huge problem, both personally and financially, and it's just undertreated. And we need to get the word out.
One thing that dawned on me too is that it's a problem that's going to grow because the baby boom generation. I don't know, what's the average age of baby boomers now? Probably 70 to
46 to 64. So
Yeah,
my dad
the
was
age-
born in
yeah,
47. He's like
right,
70,
yes, exactly.
6 this year?
So that would be something, yeah. So that we're going to have so many more people. I mean, you would assume that that's going to be a pretty prevalent problem.
Yep. Definitely for the next several decades, 30 years or so, we're going to see it.
I would think so. One thing too, and this gets a little off track, but I just thought of this as you were talking. Do we know? Is it different in different cultures and countries? In other words, is it maybe is it not as bad in say?
Do I know the
Okinawa,
specifics?
For some weird reason, has a pretty long-lived people.
Yeah.
Anyway, have we found that?
I will say I don't know the specifics on that, but I can just make some associations based on what we do know.
Okay.
Lifestyle. So not only do we try to improve osteoporosis by improving diet and improving and getting it treated, but we also encourage weight-bearing activity. So, if you're in a culture where your culture is sitting around watching TV, not getting outside, as we mentioned earlier.
Right.
Now, if you live somewhere where their culture, which may not have all the beautiful amenities of first world, but if you're in a third world country where people are out working hard in the sun for their living, then they may have other healthcare problems because of that, but their bones are most likely much better than ours.
And diet and other cultures. And so this is just a pure curiosity question. It'd be an interesting for people to do some sort of just you wouldn't even have to do a study, you know,
Yep.
if you could just take data and compare it. Well, let me ask you this, getting back. So we've learned a lot. So, you know, we've learned so much about osteoporosis, we've got better medications, but yet we're still getting 34,000 fractures a year.
Mm-hmm.
So I guess I want to ask, why is that, and what do we need to do to you know, minimize that?
Yep. We've got to get the people, you got to take care of the low-hanging fruit. And the low-hanging fruit are patients who have fractured, right? The highest risk factor for a future fracture is a past fracture. And not one that you had when you were a kid and you fell off the dirt bike, right? We're talking an adult osteoporotic fracture. And so one is education. Two is we've got to get the care providers, the people who are seeing these patients, to address it and not wait until they break. If you get a bone density and they are osteoporotic, you don't say, well, you've never broken, don't worry about it. If you have a patient who's broken 2 and 3 times, you don't say, well, I fixed it. We've got to get the providers, and orthopedics is one of the specialties that takes care of it, but I'll say it is very poorly represented. What I do is very poorly represented in our specialty. And I think it first falls on us. And then once we earn the trust of our patients, we can convince the patients to do it.
Yeah.
You know, if you advertise, there are advertisements on TV all the time for osteoporosis drugs. Direct to consumer marketing, it works to a degree, but people, they trust their doctors. They're not going to trust the TV. And if but the problem is the doctors just, it's not the first thing on their mind.
It's not a priority or
Yeah.
a big
So
priority.
I think the biggest way we can help reduce that number is during the early years, the training years, and from an orthopedic standpoint, maybe including some education on that management. The issue is most people go into orthopedic residency, they just want to be surgeons. They want to make you better in the operating room. But we can improve your lifestyle a lot more than just that.
Sure. Well, thanks for your time. That's really educational. Made me think of some things I hadn't even thought of about it.
Go check on your mama.
Yeah. Thank you so much. Great information. How can people find out more?
Yep. So they can call our office, area code 205-985-4111. Go to our website, southlakeorthopedics.com. We have information there. If they call our office, just say, I want to get an evaluation for osteoporosis, and we have people who can take care of them from there.
All right, that sounds great. So, folks, this is the end of our very first podcast, Maiden Voyage. Thank Kasuf again. This is Kasuf Studio. They've been incredibly generous to us. And don't forget the Birmingham Medical News, giving you all the information you can ever ask for about healthcare in Alabama. And just because you don't live in Alabama doesn't mean you can't learn about osteoporosis. So, thank you, everybody.